Ladies and gentlemen, we are live with Dr. Mehta and Dr. Khan, and we're talking about silicone lung toxicity from saline implants. I know this is a topic a lot of you have been waiting to hear about, so I just want to welcome Dr. Mehta. I know we had some issues with getting to this live with technology. We appreciate your patience, and we're just really excited to have you here. And Dr. Khan, thank you as usual for doing these lives for us.
You're welcome. Thank you very much. If you could please, anyone, let us know if you can hear Dr. Mehta, myself, and Alicia, and then if you're good to go, if anyone could give us the green light.
I'm going to watch for your comments. Let us know that you can hear us all.
You didn't miss anything. You're here. Yes, you can hear all three of us. All right, we're good to go, doctors. I'm going to go ahead and let Dr. Khan lead the way with our talk. If
Sure.
you do experience any problems with audio or anything bizarre during the talk, I'm talking to those in our audience, just send it over to the chat. Also, feel free to post your questions, and I'm going to try and interweave your questions into this talk as much as possible. Otherwise, the doctors are going to direct it as they see fit, and we'll just listen and learn. Okay, thank you for everyone who's here. And Dr. Khan, I'll just hand it over to you.
Yes, thank you very much, Alicia. I appreciate you setting this up, and thanks to Dr. Mehta for his time and efforts in joining us tonight and helping us understand this very interesting and very real topic. And if I may briefly introduce Dr. Mehta, he is the king of pulmonology. He's at the world-renowned institution, the Cleveland Clinic. He has the many accolades that anyone would want out of their doctor, the recognition, both national and international. He is at the Center of Excellence, working at the Heart and Lung Institute at the Cleveland Clinic. There is no other better guest that we can have tonight to talk about silicone toxicity and saline implants from a very interesting case report that I learned that my patient brought forth to me, and basically reminded me of this very important study that prompted me to ask Dr. Mehta to join us, and he graciously and without any hesitation, despite the technical difficulties that we all understand that we have had, and many thanks to Alicia for setting this up. Now, what I'm going to request, Dr. Mehta, is if you could just please summarize for us that case report in your words as to how that patient presented and how did you see the patient when she first presented, the one that you discussed that was presented and published in the Annals of Thoracic Surgery?
But the 45-year-old patient, actually, she was referred to me from a different town. She was referred to me from Houston, Texas, actually, as the referring pulmonologist had run out of options. And the thing is that this particular patient who had breast implants 18 some years ago, she was having recurrent exacerbations of respiratory symptoms. She was having shortness of breath. She was having chest discomfort. Her oxygen saturation was dropping, and she had an open lung biopsy without any diagnosis. So she came to me for a second opinion for her symptoms. So in answer to your question, her presenting symptoms were episodic shortness of breath, sudden episode of shortness of breath, dropping her oxygen saturation, chest discomfort, and all other symptoms associated with that, meaning that anxiety, rapid heartbeat, and difficult to do any type of physical activity during those episodes. She required immediate visit to the emergency room and hospitalization. I hope I'm answering your question.
Yes. Now, I will tell you, I can, and many of my patients can relate to what you just said very clearly, because this is exactly what many patients who have presented to me and that we hear. Very classically, you nailed it, just like a patient would say. Now, I saw that you basically had worked her up with a CT scan, and what did the CT scan show?
Yeah, the patient had already come with a CT scan, and the CT scan showed bilateral patchy ground glass infiltrates. Ground glass infiltrates, meaning that there is an abnormality on the CAT scan. However, through those infiltrates or abnormalities, you can still see the blood vessels and the airways through that infiltrate. So that is referred as ground glass opacities or ground glass infiltrates. They were multiple, bilateral, and they were from anywhere from size of a quarter to a diameter of an egg.
Mm-hmm. So that is pretty, interesting finding because it was on both the sides, right and left, and they were diffuse. Now, what prompted you to get a lung biopsy?
Yes. Well, the thing is, actually, we did not do the open lung biopsy. Patient already had an open lung biopsy. So patient had brought the tissue with her as per our instructions that we would like to review the pathology slides again. The pathology slides were reviewed at the primary organization or primary institution. They did send the pathology slides to another tertiary care center to be evaluated, but I wasn't fully satisfied with her history of breast implants and how did the breast implants appeared on the CAT scan. I had some suspicion that there could still be possibility of silicone embolization, and hence we just reviewed the pathology slides at the Cleveland Clinic with my pathologist, and he indeed was able to find silicone emboli within the lung tissue. And then what we did was we sent the tissue out for spectrometry analysis to confirm that what my pathologist was looking at was truly silicone. So without repeating the biopsy, we just looked at the pathology slides one more time and confirmed the diagnosis of silicone embolization.
Yes. Now, this is very classic. This is hard evidence, and this is very notable in the sense that these were saline implants, because we know if the saline implants do rupture, they essentially deflate like a water balloon, if you will, and the saline, which is essentially very benign, you can give to a newborn baby. It was not that, but it was the shell of the implant that caused this embolization to essentially seed into the bloodstream. Is that not correct from what you are concluding and deducing?
Yeah, well, that is what the notion is, that saline implants are safer than silicone implants. As stated in my article, my patients indeed had saline implants. However, one has to realize that saline implant also has a covering or a coating or a capsule that is made up of silicone. So it is not only saline, but there is silicone involved with that. And on the CAT scan, there appeared to be some, silicone implant looked somewhat smaller in size, somewhat misshapen, and it looked like the tissue around the implant was infiltrating on the CT scan of the chest. That was even though we knew it was a saline implant, we had some suspicion that this could still happen, as this patient was thoroughly worked up for all possible rheumatological conditions and for pulmonary embolism. So for the diagnosis of exclusion, we still thought that this could still be saline implant related problem, because it has a capsule which is made up of silicone.
So this is very classic how Dr. Mehta basically described the patient's symptoms when she presented to the emergency room and to his consultation. And again, what's very impressive is these ground glass opacities. And then what Dr. Mehta very clearly outlines is the multinucleated giant cell reaction, which is the reaction to the silicone. And he very clearly mentions that the silicone shell of the saline implant was responsible for these emboli, which is these small droplets, microdroplets, that shoot out of the silicone shell and then essentially travel. Now, can you please confirm with Dr. Mehta? So these silicone particles, microemboli, that basically shoot out of the capsules, are these traveling in the bloodstream from the implant and then seeding into the lungs? How did that silicone from the shell make it to the lung?
After the surgery, there is usually what we call it as new blood vessel formation, or what we call it as neovascularization. And it is very likely that small particles of silicone can enter those blood vessels and eventually end up into the lungs. Lung is a filter for the body, so all the blood has to flow through the lungs. And once this when silicone particles enter into the blood circulation through those new blood vessel formation, which occurs as a result of inflammation, that's how it gets access to the lungs. And a very simple example is, if we are not talking about the breast implants, and we are simply talking about people injecting themselves with silicone, and that's a common practice, and that is done for
Yes.
aesthetic reasons. Occasionally, they are injecting silicone directly into the blood vessels, and that's how it gets into the lungs.
Right. Now,
So
we are assuming that the way the silicone made it to the lungs, and as you can imagine, certainly, if it's true with saline, and this is a very probable and very reasonable assumption, that with a ruptured silicone implant, the silicone certainly, just like it did with the saline implant shell, that is made up of silicone, this ruptured silicone will also likewise make it to the lung as well.
Yeah, so if one of the reasons this could happen, of course, as you know, silicone is mainly a liquid. And if the silicone implant ruptures, of course, then the silicone is going to enter the blood vessels. When we talk about saline implants, it is only the capsule, and if there is any trauma to the capsule for whatever reason, then the silicone particles are going to get into the blood circulation.
Yeah.
Some element of trauma is suspected, some rupture of the capsule is suspected. It is very possible that even without the rupture or the trauma or the damage to the implant, it is very possible that the entire implant is covered with small particles of silicone on the capsule itself, and over the period of time that could also enter the blood circulation.
Sure. Now, the next point I want to bring across, Alicia, is it certainly, if it has made it to the lungs, it certainly will make it to the brain, to the liver, because the liver is also the major organ that detoxifies the body. And not only that, the nervous tissue, and then the other connective tissues, the joints, amongst the many other organ systems, and that's another fair assessment. And if Dr. Mehta would want to comment on that.
Yeah, Dr. Mehta, what Dr. Khan is saying, which is actually very echoed in the comments, is the likelihood, the probability, the propensity that, like silicone getting into the lungs, the possibility of it getting into connective tissue, blood, Dr.
Brain,
Khan mentioned
liver.
Brain, liver, kidney. I imagine, what are your thoughts on that, on it being a more broad spread issue?
Yeah, well, the thing is this. Most of the studies and most of the publications related to involvement of other body organs, it's mainly related to free injection of silicone. And that's where you have seen neurological involvement as the silicone is entering into the blood circulation. And also it has produced what they call it as chronic silicone embolism syndrome, that repeated injection and body is reacting to the silicone particles. Besides just embolization, there is a systemic reaction to the silicone emboli, which we have seen also in fat embolism after fracture, after fracture of long bones, large amount of fat from the bone marrow entering the blood circulation and causing similar problems. So yes, there is a theoretical possibility that implants could do the same thing, but most neurological symptoms and most neurological damage is seen following free injection of silicone, and that is seen in individuals who are trying to change their looks and so on and so forth. And deaths
Mhm.
have been reported as a result of neurological involvement as well.
Yes, yes,
Dr. Khan,
because
would you consider the exposure of free injection of silicone similar to a rupture?
exactly, because what happens, like Dr. Mehta very clearly mentioned, the silicone makes it into the bloodstream, and then it now has the freedom to go wherever the blood is going, which is essentially to any parts of the body. And in many patients that the silicone is injected, there are some patients where if it's injected directly into the bloodstream, it basically serves as a stroke or a heart attack waiting to happen, because what it does is it blocks the blood vessels, and as a result leads to the death of the patient, if and especially. And so silicone injection is illegal. There's so many patients I've seen, and actually a patient that I've managed who had almost 100 injections of silicone into each buttock area, which I've mentioned on the
Okay.
previous Facebook Lives. And the poor lady had what she described as worm type feeling, like worms going down her leg into her lower extremity because of the gravitational effect. And is in some patients where the silicone gets embedded within the bloodstream, it actually has led to the patient's demise because it cuts off the circulation to that one organ, sometimes to the brain or to the heart. Now,
And
going
Dr.
back to
Mehta,
what
just to let you know what Dr. Khan just went over, he was talking about the danger of silicone in the blood. So free, well, how did you reference that free, uh, just
so the
oh,
so injection
injection?
of free silicone or
Free
industrial
Right.
injections,
grade silicone.
yeah,
Yeah.
it it is very likely, even though it is considered that silicon is an inert substance, it is likely that it can cause in certain individuals an inflammatory response, and
Mm.
this inflammatory
PII.
response is responsible for other symptoms related to silicone implants or silicone injections. And this inflammatory response can cause uh, muscle pains, body weakness, muscle weakness, low grade fevers, and it may mimic rheumatoid arthritis, or it could mimic systemic lupus erythematosus.
Mm.
But all other tests are usually negative in these individuals, and therefore we make the diagnosis by excluding all other possibilities. And if the patients have got implants, we say it could very likely be as a result of silicone implants.
Dr.
It is
Mehta
also
nailed it.
interesting that
Yeah.
say that there is some portion of individuals who receive the breast implants also are doing free injections. So on occasion,
Mm-hmm.
it becomes difficult for us to decide whether it is coming
Mm-hmm.
from the implants or it is coming from the free injections.
Now,
Right.
Dr.
In
Khan, did
our
you say something about it being in the blood or blocking blood vessels, or what was that?
right now, this is when the free grade silicone is injected, which is illegal. It is a malpractice to inject free grade silicone into the body. And we see a lot of cases out of New York and the state of Florida where many of these are done at homes and by non-MDs and not plastic surgeons. Now, going back to what Dr. Mehta says, this is classic story of many of my patients who will relate to what is BII, breast implant illness, which is the inflammatory phase of the entire body reacting to the silicone. And we also know from the cadaveric study that was done where a patient who had ruptured silicone, and this is in my Facebook pages, which we will bring it up and highlight as a announcement, where the lady had a rupture of the silicone, and very nice, generous lady after her death donated her body to science, and these group of doctors and scientists actually biopsied her nervous tissue, her brain / the rest of the tissues of the body, and concluded, just like Dr. Mehta did, and in his paper where he showed that the electron microscopy and the energy dispersive spectroscopy clearly 100% showed that there was silicon embedded within all these tissues, just like it was embedded within the lung of his patient that he described in his case report. So again, there is a and I'm amazed how well Dr. Mehta has described our patients that they all can relate to. Now, having said this, yes, please go ahead, Alicia.
Dr. Mehta, I just want to share with you the things that Dr. Khan was saying. And if there is an extra cell phone around either of you, we could connect you, the two of you, on a cell phone to just have the audio next to you. You just have to mute it out. But I'll do my very best to convey everything, and then we'll fix the audio.
Yeah.
What Dr. Khan was referring to was a patient who generously donated their body to science and actually studied and they were able to identify a lot of these issues that you're discussing with silicone in the blood, and also that it's what you're describing as far as symptoms is telltale of his patients, that they just come with
the ruptured silicone
symptoms, ruptured silicone, the
electron microscopy.
Electron microscopy.
Yeah.
So Dr. Khan does have a question for you. Did you have a comment on that?
Yeah, I do. I do.
He has a comment, Dr. Khan.
Yeah, the thing, the audience can hear me, correct?
They can.
Okay. So in response to Dr. Khan's question, actually we did think about this, and I'm in a unique situation. As Dr. Khan may have mentioned, that I'm a lung transplant physician, and at the Cleveland Clinic we do large number of lung transplantations, on an average about 100 transplants a year or more. What I'm trying to say is, after learning about this particular case, which I published in Annals of ATS, we got an idea that we went back and looked at all the explanted lungs, the lungs which were removed from the patient, and if the patient had breast implants. And we did find about 7 or 8 patients who had breast implants and they underwent lung transplantation. So we involved our pathologist and asked him to look at the pathology slides of explanted lungs. Now I want to point out that, and we didn't find any silicone emboli in those lungs. But again, I would like to point out that we did not go back and got more tissue from those lungs. We already had some slides made. There were like some patients had 2 slides, some patients had 6 slides, some patients had as many as 23 slides made. So we looked at all those slides to look for silicone emboli, and we could not find any silicone emboli in these 8 patients. However, I mean, this is not done prospectively. What I mean by that is, if I have a next patient who is undergoing lung transplantation and I'm going to have an access to her entire lung and she has got breast implants, what we should do is we make not 10 slides, but we should make 100 slides from different areas of this lung to look for any silicone emboli. That is number one. Number two issue is also important, that if suppose patient with breast implants undergoes lung transplantation and we perform what we call it as sequential lung transplantation, meaning that right after left or left after right, by doing 2 separate thoracotomy incisions on the side, we often end up removing the implants because we don't want to damage the implant, and we don't want that particular site to get infected after the lung transplantation. So we can also look at if there is any inflammation or any other tissue reaction to that implant, but that needs to be done prospectively. But there is an opportunity. We don't need to look at the cadavers or anything like that. We can look at explanted lungs among patients who have got breast implants.
Sure.
So
Now,
that would
Dr.
Really
Mehta,
fascinating.
yeah,
that would be
Dr.
Sure,
fascinating.
Lisa
Mehta,
has a
Yes.
yeah,
response to that. Give me a moment. Go
Sure.
ahead, Dr. Khan.
yeah. Quick question. Did you do electron microscopy and energy dispersive spectroscopy on these 8 patients who had transplants and who had implants?
He said, quick question, audience. Dr. Mehta, this is the question. Did you do electron microscopy and what was the rest,
Yeah.
Dr.
Energy
Khan?
dispersive, energy
Spectroscopy.
dispersive,
Energy
Yes.
dispersive
dispersive spectroscopy.
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 Right.
Yes,
Yes.
there we go.
Exactly. Yeah. The thing is this. It is very, very important. Now, as you look at it, the case which I described, and I'm sure Dr. Khan has described this case to the audience. And as I mentioned, that this patient's slides were reviewed at 2 different institutions, very reputable institutions, where the
Southwestern Medical Center,
pathologists
Dallas. Yeah.
are lung pathologists. The only thing they look at is lungs and no other body organs. Both of these institutions did not find any silicon until it came to my institution. And my pathologist said that this looks like silicon. However, and he was able to say this thing because he knew the history of the patient and we had ruled out all other conditions. But once again, to check my own pathologist, he himself said that just to confirm, yes, we do need to do electron microscopy and we need to do spectroscopy. There is a lab in Buffalo, New York. They can put all these different type of minerals and chemicals under spectroscopy, and that clearly showed that the particles which we were looking at were indeed silicon particles. There was no sodium, there was no silica, there was no calcium, there was some carbon, but there's a huge spike of silicon. So confirming that this is this type of this is a silicon embolization. Now one can go even further, and spectroscopy can tell you different types of silicon as well, and it can you can actually make the diagnosis whether it is a free silica which was used or if this is coming from a silicone implant or the saline implant.
Right.
So that is
So
that
this
is
is,
indeed a confirmatory test.
yes,
Thank you,
yes, and it
Dr.
is a
Mehta.
hundred
Dr. Khan,
percent
go ahead.
diagnosis. It is 100% diagnosis
Dr.
because
Khan said it's
electron
100%
microscopy
diagnosis.
and
Yes.
energy dispersive spectroscopy is the diagnosis. It is the confirmation. It is proof.
Okay.
It is like me talking to Alicia and Dr. Mehta. It is direct evidence. Now, the next question here is this. I have a patient who I recently talked to 3 weeks ago. She's 45 years of age, a nurse, and she has gone to the Mayo Clinic. She's been intubated 10 to 12 times. The
Okay, Dr.
entire
Mehta,
workup. Yeah,
I'm going to give you your next question. I'm going to convey it just kind of in parts so that I can make sure I get it accurately. And
sure.
so,
You can go ahead and why don't you say it, and I will let you. So, 45-year-old lady has
the
been intubated,
45-year-old lady, she's
put
been
on a
intubated,
ventilator 10
put on
to
a ventilator
15, 10 to
10 to
12
15 times,
times,
10 to 12 times. Okay.
and is being worked up at the Mayo Clinic.
She's being
The
worked up at the Mayo Clinic.
pulmonologist, his colleague at the Mayo Clinic, has exhausted all avenues, all the tests, all imaging, all CAT
So the
scans.
pulmonologist at the Mayo Clinic has exhausted all tests, all CAT scans, all examination. Go ahead,
CAT
Dr.
scans
Khan.
are very much suggestive of these ground glass opacities.
And the CAT scans are
The
very much suggestive of what, Dr. Khan?
ground glass opacities,
Ground glass opacities.
Right.
like he described. And
Uh-huh.
this patient is a nurse. She
And this
has no
patient is a
silicone
nurse.
injections,
Okay.
just
She's
like
had
Dr.
no
Mehta's
silicone
patient.
injections.
This is a very similar case. It's pretty much the same age, the same presentation, and she is a exact patient that I would say I would want, number one, either to remove the implant and see how she bounces back,
Okay.
or in order to get a diagnosis, at least get an open lung biopsy out of the right upper, middle, or lower lobe, and
So
all
Dr.
three.
Khan is saying that this is the kind of patient he would either recommend having the implants removed to see how they improve, or doing a lung biopsy. You said certain regions, Dr. Khan. You said
Yes, yes, so right upper, middle, lower lobe,
right
like was
upper,
done
middle,
in Dr.
lower,
Mehta's patient,
like was done in this
because we
patient.
need. It is only a
Yeah,
matter
but the
of
thing
time.
is, in
Yeah,
this
before
situation, if all other conditions have been ruled out, then lung biopsy is recommended. That is number
right.
one. However, got to realize that if this patient is so severely ill on the ventilator, and if she's not able to maintain oxygenation before doing the open lung biopsy, I would stabilize the patient. What I mean by that, this patient should be treated with steroids. This patient should probably be treated with mycophenolate, and under the dire circumstances, one can consider plasmapheresis on these patients to get as much silicone out of the body or whatever bodily reacting substances are. That should be done to remove the ill effects before we do the open lung biopsy. What I'm trying to say that I would rather do the open lung biopsy during stable situation. If you're telling me that she has been intubated 12, 15 times, that means she has got episodic illness, and in between the episodes, she is stable. So I would not only just go after the upper, middle, and lower lobe, but I would focus on where the ground glass infiltrates are and would do the biopsy of those areas.
Yes, very
Okay,
important.
Dr. Khan, your response.
And yes, so this is a lady. She's already on the steroid and she's already on the CellCept, which is the a transplant medication in order to suppress the immune system, like Dr. Mehta very well said. And she and I talked, and we talked about Dr. Mehta, and basically we are basically waiting for her. Now I told her we can cut to the chase and remove the implant because ultimately that's where she's going to head to, and save herself a lung biopsy, which is a pretty invasive procedure. But again, outpatient and relatively well tolerated. When I use the word, it's a relatively straightforward procedure. That will entail a chest tube, and because we need to get a diagnosis, because it's only a matter of time before she's going to be intubated, unfortunately, one more time again, before any of this would eventually be done, and hopefully never, but we know that that is only going to happen. Now, going back to his patient, when the implants were removed by the plastic surgeon, how did the patient fare overall?
Dr. Mehta, going back to your patient, when the implants were removed, how did the patient feel overall?
The patient did not get better instantaneously, and she continued to have problems at least for a year after the transplant were removed. She did require, plasmapheresis, as I mentioned, but over the period of time, the severity and the frequency of her symptoms have slowly getting better. So, again, as you know, that she was referred to me from a different institution, from a very good pulmonologist. So he is looking after her now. But when I talked to him last time, the severity and the frequency of her acute shortness of breath, those symptoms have been getting better over the period of time. Now, this is almost 3 years ago. So it took her about a year, year and a half after removing the implants that she has started feeling somewhat better.
Good to hear
Sure,
she's
and this
starting
is
to
because
improve.
the
Go ahead,
silicone.
Dr.
Why
Khan.
is that? Why is that the case? And I'm assuming because the silicone is embedded within the lung, and the plasmapheresis for those patients. If can Dr. Mehta describe what is plasmapheresis for the patients out of his own words?
Dr. Mehta, can you explain to us in your own words what plasmapheresis is?
Yeah, it's basically when patient, besides in our blood, besides the red cells, white cells, platelets, there is plasma which circulates through our circulatory system, and whenever there is an exposure to a new substance in the body, for an example, let's say you get a blood transfusion and there are certain antibodies or there are certain antigens in the transfused blood, the body would make antibodies to that particular antigen. And to remove those antigens, you need to remove patient's bad plasma and replace it with a fresh plasma. Let me give you a perfect example where we use plasmapheresis. A patient gets a solid organ transplantation. Patients get a kidney transplant, patient gets lung transplant or a heart transplant. And of course, this is somebody else's organ, that's a different antigen. And on an occasion, if there is not a proper match done, the body produces something called as antibodies against this solid organ. Now, these antibodies would hamper the function of newly transplanted organ, that is kidney, heart, or lungs. So, to treat this type of antibody mediated rejection, we do plasmapheresis. We filter the patient's plasma, remove all these antibodies, and when we filter the patient's plasma, we replace this thing with a fresh plasma from the donor. And we occasionally also replace antibodies which we have removed. We give them fresh antibodies so that patient does not become immunocompromised. Patient does not become deficient in defensive mechanism. So we give them IV IgG infusion to maintain patient's immunity. So in a nutshell, that's plasmapheresis.
No, thank you very much for essentially cleansing of the plasma and clearing it and filtering it, just like hemodialysis would, but in this case, just focusing on the plasma. Thank you very much. Now, question. The patient improved slowly, and obviously you cleansed and the body itself kind of detoxified wherever the silicone was embedded, it essentially over time just got diluted and there was no further burden. So the patient improved when the burden, the insult, which is the shell, the silicone shell of the saline implant, was removed very carefully, and the patient bounced back. Now, next question. Did this patient have the capsules removed? And you very well mentioned that the silicone seeds out of the shell of the saline implant and embeds within the periphery, the tissue, and hence leaches into the blood and hence travels via the blood into the lung. Now, the next question here for you, sir, is this. I just also want to make a point for my viewers. Saline implants are like silicone implants, and the analogy that I like to make to my patients is, a cigarette with a filter is not safe like a cigar without a filter. Both are equally dangerous and they both harm the body, and there is no such thing as a safe cigarette and there is no such thing as a safe implant, because both of them have the silicone that the body in itself recognizes as foreign and hence continues to mount that immune response. Now, next question. Would you recommend a young lady 22 years of age to get saline or silicone implants from what you have read and heard?
Okay, Dr. Mehta, we have two questions. First, on this patient, do you know whether or not when the implants were removed, whether the capsule was also removed along with that? And the question is related to the notion that silicone from the casing actually kind of shedding into that surrounding tissue and getting into the bloodstream or getting so do you know with your patient whether the capsule was removed?
Yes. Well, the thing is, both implants were removed completely. And interestingly, there was no tissue invasion with the implant, and both the implants were intact. So the CT scan was overread in terms of damage to the implant or any other things. There was very minimal inflammation around the implant area, multiple biopsies were also obtained from the surrounding tissue, and there was no silicone invasion seen in the surrounding tissue. Multiple biopsies were obtained, but that was, of course, at a different institution. We were not able to get those slides because patient didn't come back and didn't bring those, didn't send us those slides. But yes, we removed the entire implants from both the sides in this particular patient. I hope I'm
Sure. I
answering.
just want to emphasize the capsules were very likely left behind, which is considered the standard of care across the country. And I'm almost certain of that because unless we get the operative record, we will not be able to conclude definitively. Now, if you could ask Dr. Mehta, are saline implants or silicone implants safe? Would you recommend a 20-year-old getting them?
Dr. Mehta, we'd like your opinion of, are silicone or saline implants safe? Would you recommend a 20-year-old getting them?
I'm a pulmonologist, and I'm in practice for almost 40 years now. This is my 40th year of pulmonary practice at the Cleveland Clinic, 30 years with lung transplantation. Since I published this particular case, I have seen 3 other patients with similar problems. I'm not bragging about making 3 diagnoses. I'm worried about how many diagnoses I have missed in my last 35 years of practice. That is what I'm concerned about. To be honest with you, no, I would not recommend a 20-year-old getting breast implants, either silicone or saline implants, for cosmetic reasons. Medical reasons is something different, because you never know, who is going to get this. Again, I agree that the incidence of, there are so many transplants being placed every year in this country, and Dr. Khan can tell you exact numbers. And the number of patients getting this type of systemic syndrome or embolization are so few. However, there is no data, or there is no science which can identify the individuals who are going to have problem from silicone. So my recommendation, being a pulmonologist, is no. I want to protect your lungs. I want you to protect your health of your lungs. So my answer is no. I'm sorry I'm giving you a long answer to a short question.
That's a good answer. Thank you.
God bless Dr. Mehta. This is, very informative for me, and I'm sure the patients. Now, if you could please, Alicia, I'm sure you have a lot of questions from the audience. Please ask any questions that anyone may have that our nice guest and honorable guest can answer.
Perfect. Yeah, let me look through here. We did actually have several that were coming in, and you were answering them by default. So that was good. We've got a lot of personal experiences being shared, and a lot of women who want to know how to get tested to find out whether or not there is silicone just free floating in their body and their organs and their lungs. I know you mentioned the process, but is there something more you can add?
If they have any unusual symptoms, I think the first they should contact a rheumatologist, and they would do testing to find out they don't have anything similar to lupus or rheumatoid arthritis. If you have any slightest symptom of shortness of breath, or what we call a dyspnea on exertion, that you are getting fatigued very easily and unable to do physical activity because of shortness of breath, you should have a breathing test done that includes spirometry and a diffusion capacity. This should be followed up by chest x-ray, and if needed, a CT scan of the chest. I would say you can skip the chest x-ray and go directly to the CAT scan of the chest if you really have a concern regarding shortness of breath. Ground glass abnormalities, which Dr. Khan mentioned and which has been seen in patients with silicone embolization, can often be missed on chest x-ray. So the CT scan of the chest would be more beneficial. CT scan of the chest would also give you information on the integrity of the silicone implants, whether it is intact, whether it is ruptured, whether it has changed in the size. Very often I have seen significant calcification around the silicone emboli as well, and that could be occasionally painful and disfiguring. So I would say if you have any pulmonary symptoms, get a breathing test, includes spirometry, diffusion capacity, and a CT scan of the chest. You have any systemic symptoms, then go to a rheumatologist and make sure you don't have lupus or rheumatoid arthritis.
If I may ask a quick question, we know from what Dr. Mehta very smartly and intelligently said that the silicone made it and leached out of these intact saline implants from the shell and made it into the bloodstream and ultimately into the lungs. And both the lungs, and in some areas of the lungs there was more, and in some areas there was less. And hence he has directed, if at all, and when needed, appropriate biopsies of the areas that have these ground glass opacities, as you will see in the paper that Dr. Mehta. Now, what I am suggesting, I'm a biochemist from my undergrad when I was at UT Austin. I'm a Longhorn. What I would suggest is maybe taking a blood vial from a patient or two, spinning it down, and maybe doing what is this electron microscopy, mass spectroscopy, i.e., a energy dispersive spectroscopy, and maybe looking at silicone within the blood, especially in ladies that have had ruptured silicone, because that is a good test. Because remember, we don't have any lab tests, we don't have any imaging tests other than what we hear about the MRIs or the CT scans. So this might be a good way for us to quantify and evaluate, just like this lab in Buffalo, where we can further investigate the blood and say, well, you have this high toxicity of silicone in the blood. And this is just a thought process, a proposal. If there are any biochemists, biomedical engineers out there, this will be a nice way where we can do, like say if someone has tingling, numbness, or maybe some connective tissues, where a biopsy will be readily achieved, where we can conclude, just like in that cadaveric study, where this nice, generous lady, may God bless her soul, who donated her body to science, who had ruptured silicone, where they biopsied different tissues of the body and concluded that this patient had silicone deposited. And so what I propose is, this will be a nice way to conclude if there is the silicone toxicity, because this is how it spreads to all the organ systems of the body and affects the whole body, from the hair follicles down to the eyes, down to the mucous membranes, the teeth, the neck, back pain, amongst all, to the toenails, as you can imagine. Now, having said this, Alicia, please go ahead and ask any other questions that the audience may have, please.
Yeah, we've got a lot of questions coming in, a lot of comments, a lot of just curiosities on this. Is silicone in the blood something that your body can heal from, or does it really need to be addressed and treated?
It's a difficult question. No answer. I do not have the answer to this, but silicone is considered as a benign substance, or what you call inert substance. Let me just give you some other examples. That we put stents inside the lungs as well. When patient has got damage to the windpipe, there are small tubes are placed inside the windpipe to support the trachea or the main bronchus. And majority of these stents are made up of silicone. Even if we put a metallic stents inside the lung or inside the windpipe, they are covered by silicone. So, silicone is used in many different forms in the body to support the structures, especially the stents in the windpipe. There are stents also placed in esophagus. There are stents placed into the gallbladder ducts at times, and they have some amount of silicone as well. So it is not that something which is always going to cause a problem. There are certain benefits, and not all the patients develop silicone going into the blood circulation. If appropriately placed and appropriately followed, and if there is sign of any reaction, that is, it is taken care of, then it is safe to do so. I hope I'm answering your question in that fact.
Dr. Khan, anything on that?
No, I'm good. Please continue. We want to ask as many questions that the audience may have, please.
Okay, and I've got some questions that may not be as pertinent to this talk, and so maybe you can just give a quick answer to these. I have some of our audience that are wondering, they have all the symptoms that Dr. Mehta is mentioning and you, Dr. Khan, but two of our audience members say they're over 70. Am I too late to explant? Does the risk increase too much? So, Dr. Mehta, would you like to speak to that first?
Yeah, no, absolutely not. If you have a good plastic surgeon, age has nothing to do in explanting the implants. In fact, my last patient, as I mentioned to you, she was in her 70s, and interestingly, her both implants are very much calcified. Even then, they were removed very successfully by a good plastic surgeon without any complications.
Absolutely, I couldn't agree with Dr. Mehta. Age is not a reason. If you're old doesn't mean you cannot get the quality of care. Every single person from newborn to whatever age they're entitled, they should not be in misery. They should not be suffering. I have operated on an 81-year-old lady with breast implants. She was riding her car, and the airbag literally traumatized her chest, ruptured the silicone implant. She had a hematoma. I operated on her, and she did very well. Her quality of life improved. The 69-year-old, the 68-year-old, the 73-year-old. So there is no indication to defer someone else or say no to. No matter what, if you are on blood thinners, you're entitled to the best surgery. If you are on immunomodulators, any agent like prednisone, for example, or your adrenals are basically atrophied, whatever problem it may be, if you have had strokes, seizures, there is no indication to say, well, you're not a candidate for surgery. I could not agree with Dr. Mehta. You're entitled to the best health care if done right. You absolutely can be managed very safely. Some of the sicker patients with pacemakers, for example, or type 1 diabetics or heart issues, heart attacks, patient with stents I've operated on at the hospital very safely, and I offer them the same quality of care that I do to the 21-year-old that I did operate on, or the 28-year-old, because they're entitled to the best health care. Age is not a reason to compromise the surgery.
And Dr. Mehta, Dr. Khan just emphatically agreed. He said absolutely, quality of care is not factored out by age. Okay, so another one of our guests is talking about a kind of a frustration with that deductive, my feed just moved, rule out testing, like going to get tested for lupus, going to get tested by a pulmonologist. And just a lot of us who deal with breast implant illness, it's not on a physician's radar to identify that as a problem. And so I understand this person's frustration because we don't get that information.
Right.
And so for myself, I went to doctors for 10 years and got no answers, and came across Dr. Khan on Instagram of all places. So I understand that frustration, but can you still tell us why that's important, why you advocated for that?
Well, the thing is this, it is, if patient realizes the problem, that is one issue, but look at my situation. Patient may have breast implants, patient has all these symptoms, patient is usually not giving me that history of implant intentionally or unintentionally. And that is the biggest frustration from the physician side, that when we do not have the history, or patient is hiding the history. And again, this days and age, the physical examination is very limited in that regard, and if we miss that history, it takes us such a long time to suspect something like that. Okay, there is no specific, and if we know the history, still it is so difficult to make the diagnosis because there is no specific test except the open lung biopsy and spectrometry, and which could also be falsely negative in many of the patients. So it remains the diagnosis of exclusion. So basically what my saying is that you have to have a constant vigilance and high you have your high suspicion for this condition. So this is what I do nowadays, that any patient who has got breast implants and they come to me for any pulmonary problems, I would certainly do the breathing test, do a CT scan of the chest, and if they have any systemic symptoms, I order rheumatological tests, and then try to correlate those findings with patient symptoms. So constant vigilance and high degree of suspicion is required to make such diagnosis on the part of the patient as well as on the part of the physician.
Very good. And Dr. Khan, I want you to add to that, but I want to just say that as a patient, a lot of us have had to be hypervigilant, and I just want to encourage you that part of why we do this, part of why Dr. Khan gets online and does these talks, is so that more physicians have that awareness, like Dr. Mehta.
No, it is very important what Dr. Mehta very brilliantly said, that you have to do your homework. We don't want to miss lupus. We don't want to miss, God forbid, Lyme's, which is basically where the docs start like hunting or looking at, or basically rheumatological problems, because we don't want to attribute any of these problems. God forbid, it may be that. Once we have excluded those, and Dr. Mehta said very nicely, it's a diagnosis of exclusion, because all the fingers now are pointing towards BII, because it's this whole pattern recognition of this gross inflammatory response that the body does in an effort to protect itself from the implants. It overshoots and hence compromises the whole quality of life as a result. Any other questions, please, from the audience?
Okay, let's see. I've got a lot of discussion in the audience of just amongst themselves about things they're going through and they've been through. Let me see. Give me a moment to find another question. Just a lot of connecting the dots and what you're saying. A lot of people with that have had respiratory issues for years and that want to follow up. Dr. Khan, I think one thing that I'd like to do, and I'm frozen here, so let me see. Let me pull myself back in.
Yeah, one thing I just want to mention, patients who get saline implants, you measure the weight of the implant and the saline and the implant itself. And then studies have been done. When the implant is removed, they find out that the weight of the saline and the implant is basically heavier, different than what it was. You know, there is crosstalk, there is information flow, i.e. leakage, seepage, and seeding of what is the silicone, and hence this is what ultimately is the breast implant illness. Yes, the gummy bears implants may be there, the neo generation, but guess what? They are inert, but they are reactive, and hence it is all this reactivity that ultimately leads to what is the breast implant illness. Another question I may have for Dr. Mehta, if someone has silicone that is embedded within the lung, and he's the king of lungs, the king of pulmonology, how can we improve, other than plasmapheresis, what else can we do to detoxify, to help our bodies, in addition to the plasmapheresis, so our symptoms, the symptoms of the many patients improve? Yeah, if you could please ask, what can we do to detoxify the lungs, to eradicate and remove the silicone, for example, in his patient, in order to enhance the quality of lung function? What is it that can be done? Because many ladies come and say, what and how can we detoxify? And I say the best detoxification is to remove the entire implant plus the capsule as one system, which is called the en bloc method, or 100% total capsulectomy, because this gives the chance, the body, the due chance to recover and bounce back. What is it, as a pulmonologist, as a king of pulmonology, what can he tell us that we can do, or the patients can do, in order to bounce back to their normal state of affairs after the implant is removed in the en bloc or the total 100% capsulectomy method?
Okay, Dr. Mehta, Dr. Khan is asking, and this is actually echoed in the comments with our audience, is what can patients do after that explant, after the total capsulectomy, after they have had their, surgery to restore your lung health and to detoxify, if you will, and any kind of advice you can give along those lines for treatments or.
The
Is that okay, Dr. Khan?
Yes, thank you.
Okay, go ahead.
Yeah, after the implants have been removed, that does not mean that the disease would completely disappear, and that again, follow up with the pulmonologist is required. Many of these patients may still be on prednisone or cortisone, on other medications to suppress the immune system. So, close follow up is required to slowly taper off these medications. And while tapering off these medications, one has to make sure that the disease does not flare up again. So, yes, after the surgery is done, of course, make sure the surgeon is surgeon is going to do his job, taking the implants out, and if there is any leakage or anything like that, the entire area would be cleaned and make sure there is no infection. But until the time that patient is completely off all the immunosuppressive drugs, a close follow-up with the pulmonologist or rheumatologist would be required. I forgot to mention one other thing, that there is an entire science on the entire radiology science on making the diagnosis of ruptured implants and displaced implants or the inflammation around the implants. So a good radiologist can diagnose any kind of damage to the implants.
Very good, thank you. Dr. Khan, any follow-up
Yes,
on that?
Yes, the gold standard is the MRI without contrast. This is the best of all the tests that exists in 2020. MRI without contrast. This is where we can conclude with definitive certainty. The best study that we have, and even then, that is not the ultimate of all the studies, because there are times where I've gone in and the intact implant has been mentioned, and lo and behold, when I do the implant evaluation at the end and conclusion, I find that the implant indeed has been very much ruptured, which basically is contrary or different from what the MRI reading was. Now, if I'm not mistaken, I heard Dr. Mehta a little while ago that I think he may have a commitment, or I think he might be getting ready for dinner. If that is true, Dr. Mehta, I cannot thank you enough. You have opened my eyes, about how the blood in itself and tests, the spectroscopy, this lab in Buffalo, how you have concluded and documented how you have presented. The very first part, where how your patient presented with the shortness of breath, anxiety, what they call dyspnea on exertion, which means with some exertion you basically get short of breath. All these rheumatological/lupus type of evaluations management. And God bless you for your time and effort, and for a wonderful discussion that we had. And this is what you call the center of excellence again of the world, the Heart and Lung Institute of the Cleveland Clinic. And you are the man. And when it comes to lungs, you have certainly helped me, and I'm sure, Alicia, you too. One thing I just want to mention, there are patients that have had their implants ruptured spontaneously or sometimes deliberately. There are implants that are left within the body. I have a patient that we heard of just recently who had calf implants inserted on her calf that are continuing to, and she has had no injections or no, from what I've heard, these are the same, the body is reacting, and the patients need to understand and realize that there is a certain etiquette of managing implants and removing them, and what Dr. Mehta has explained to us from his very eloquent conversation tonight as to how to best manage. Thank you so much, Alicia. God bless you for your time and efforts, the many, many hours you have spent in order to make this happen. And Dr. Mehta, I just want to say I initially did not know of Facebook at all. Alicia was the one who set up my Facebook page, and only the credit goes to her and no one else for making it happen. And she has literally helped thousands of women, and she continues to support this very noble cause and helping us understand this mysterious but very, what I would say, very evil disease of what is breast implant illness.
Evil is a
Dr.
good word
Khan, I
for
can
it,
see
Dr.
you now
Khan.
and I can hear you clearly. I mean, I don't know what Alicia did, but she waited for the whole hour and a half to this thing to happen. Maybe next time it would be better. So,
Dr. Mehta.
this is, I appreciate the opportunity, and I fully agree with you that, I'm a transplant physician, and sometimes I wonder what I'm doing with the lung transplantation, that I'm trying to fight against the nature. And the nature gets back to us one way or another, with lots of side effects and stuff like that. So this has to be done very carefully, very selectively, and it is not for everybody. I always tell my patients that, I wish and pray that you never need me for anything. So, and you try to do everything to protect your lungs. Okay?
Thank you, Dr. Mehta.
Thank you so much for the opportunity. I appreciate it. Now I cannot hear Alicia.
Yes.
Okay, hold on.
Okay.
Yeah.
Okay, can you both hear me now?
I can hear it, and I can see Dr. Mehta very well. Yes.
Okay, then I just, you were able to hear each other?
Well, thank you, Dr. Mehta, and it's an honor to have had this discussion with you.
You're too kind.
God bless you for all the noble work and the thousands of patients you've helped your entire career. Thank you.
Thank you.